Welcome to the Deep Dive, where we cut through the noise to bring you critical insights on topics shaping our world, often with a clinical lens. Today, we're plunging into a subject that's not just rapidly transforming healthcare, but fundamentally redefining the landscape for medical professionals: the pervasive integration of artificial intelligence and digital tools. The potential here for unprecedented efficiencies, for truly personalized patient pathways, and, well, for revolutionizing health outcomes, it's immense. It's a future many of us are actively building towards and, frankly, eagerly anticipating. However, as with any powerful and rapidly adopted innovation, there are critical ethical challenges, systemic pitfalls that are often overlooked, particularly concerning issues of bias and inherent inequality within these digital innovations. And to help us navigate these complex, often uncharted waters, we have with us an expert in this burgeoning field.
Thank you for having me. It's a critical time to be discussing these issues.
Indeed. Our mission today is to unpack precisely how digital health technologies, especially AI, can inadvertently perpetuate or even exacerbate existing health disparities. And crucially, what we as medical professionals can and must do about it. This isn't just academic, it's a vital discussion for anyone involved in modern healthcare delivery and strategy, from the clinician on the ward to the leader shaping national policy. So let's get stuck in.
Absolutely. Ready when you are.
Imagine a future where the very systems designed to care for us silently misinterpret our health needs, even downplaying symptoms simply based on gender. That chilling possibility isn't far off. In fact, new research suggests it's already happening, particularly for women. Can you tell us more about these compelling new findings?
It is a profound concern, really striking at the heart of equitable patient care. This insight stems directly from recent and, quite frankly, alarming research from the London School of Economics, the LSE. Their study used a very meticulous methodology to look into potential gender bias within large language models, or LLMs.
Right, the AIs like ChatGPT that process and generate language.
Exactly. The researchers took real case notes anonymized, of course, from over 600 adult social care users. They inputted these notes into two prominent LLMs, Google's Gemma and Meta's Llama 3. But the crucial step, the really ingenious part, was inputting the exact same case notes multiple times, only swapping the gender of the individual.
So Mr. Smith becomes Mrs. Smith, but the clinical details stay identical.
Precisely. It allowed them to rigorously analyze how the AI models summarized identical clinical information when attributed to a man versus a woman. They looked at nearly 30,000 pairs of summaries.
30,000, that's thorough. And what did this forensic analysis reveal, particularly with Google's Gemma?
Well, with Google's Gemma, the findings were stark and deeply worrying. The language in the AI summary showed a significant quantifiable gender disparity. Words conveying severity, need or impairment, like disabled, unable, complex, they appeared substantially more often in descriptions of men, almost by default.
And for women,
Yeah.
with the same needs.
That's the crux of it. When the exact same care needs were attributed to women, the language was notably different. Those needs were either more likely to be omitted entirely from the summary,
Omitted.
yes, or described in far less serious, almost dismissive terms.
That's incredibly subtle, yet potentially devastating. Can you give us some specific examples, something that really brings this home for a clinician reading these summaries?
Absolutely. The study provides concrete examples that highlight this insidious bias. Imagine identical notes detailing health and social situation. For Mr. Smith, the AI summary might say, an 84-year-old man who lives alone and has a complex medical history, no care package, and poor mobility. Seems reasonable.
Okay.
Now, swap the gender. For Mrs. Smith, the summary for the exact same case notes could bafflingly read. An 84-year-old living alone, despite her limitations, she's independent and able to maintain her personal care.
Wow. Independent despite limitations. That's a huge interpretive leap.
It is. Or another example, Mr. Smith described as unable to access the community, whereas Mrs. Smith was simply noted as able to manage her daily activities. What this chillingly reveals isn't just a glitch. It's a silent automation of neglect. It shows how deeply ingrained societal biases can be amplified by technology, creating a digital filter that literally diminishes women's suffering and their access to care, often before a human even reviews the case.
And the implications, if perceived need dictates care provision.
Exactly. If an AI systematically downplays women's health issues, it could lead directly to unequal and insufficient care, a two-tier system created by algorithmic design.
So if Gemma is doing this, is this a universal problem with all LLMs? Are they all susceptible?
Well, it's important to note this specific bias wasn't universal in their test. Meta's Llama 3 model, for instance, didn't show similar gender-based language differences.
That's interesting. So it varies between models.
It does, which underscores the critical need for model-specific evaluation, rigorous validation, and transparency when these tools are deployed. You can't assume one model's performance reflects another's. And the urgency here really can't be overstated. These AI tools are already widely used by local authorities, even here in the UK, to manage social worker workloads, triage cases.
Already in use.
Yes. Yet there's a concerning lack of transparency about which specific models are being used, how often, and their actual impact on decisions that determine whether someone gets care or not. This isn't hypothetical. It's happening now.
That's a truly chilling thought, especially how foundational those initial assessments are for a patient's entire care pathway. Professor, this isn't an isolated incident, though, is it? We've seen concerns about racial biases, other forms of gender bias in AI tools across sectors for a while now. This LSE study feels like another stark piece of a larger, worrying puzzle.
Absolutely. The LSE findings fit squarely within that broader landscape of algorithmic discrimination in medicine. The root cause often traces back to how machine learning works. These systems learn by identifying patterns in vast datasets. If those datasets contain inherent biases from human language, historical data collection favoring certain groups, simple imbalances, the AI absorbs and propagates those biases, often amplifying them.
So the AI learns our existing biases.
Precisely. We can generally think about bias in AI in three ways: data-driven bias, algorithmic bias, how the algorithm processes data, and human bias, introduced by designers and users. They often intertwine, making it complex. Let me give you some concrete examples of how historical biases are unfortunately being amplified. Take racial bias. We've seen deeply problematic instances. Consider pulse oximeters. Those little devices we routinely clip on a finger to measure oxygen saturation.
Standard kit.
Standard kit. They work by sending light through the skin. The assumption has been they work universally, but studies have shown they can systematically overestimate oxygen saturation in non-white patients, particularly those with darker skin tones.
Overestimate. Why?
It relates to differences in melanin absorption affecting how the light passes through. And this isn't a minor discrepancy. Black patients, for instance, are found to be 3 times more likely to suffer from occult hypoxemia.
Meaning dangerously low oxygen levels that the device misses.
Exactly. Hidden hypoxemia, the clinical consequence. Delayed oxygen therapy, delayed critical interventions, potentially poorer outcomes. The AI processing this imperfect data from the device generates a biased reading.
So the technology itself has a blind spot based on skin color, and AI interpreting that data reinforces it.
Precisely. And it extends elsewhere. Dermatology, for example. AI tools called convolutional neural networks, CNNs, can classify skin lesions with high accuracy.
Like a digital eye spotting patterns.
A very specialized digital eye. But many are trained predominantly on images of white patients. Some datasets have as little as 5–10% images of black patients. Yet many conditions, like inflammatory diseases or even early melanoma, can look different on different skin tones.
So the AI hasn't learned to see them properly on darker skin.
That's the result. When tested with images of black patients, diagnostic accuracy can drop by half. This directly contributes to existing disparities. Think about melanoma survival rates. 70% 5-year survival for black patients compared to 94% for white patients. Biased AI contributes to that tragic gap. Another deeply concerning example involves AI managing population health. Some algorithms controversially used historical health costs as a proxy for health needs.
Cost as a proxy for need. That sounds flawed from the start.
Highly flawed. It led these algorithms, in some cases, to falsely conclude black patients were healthier than equally sick white patients simply because less money was historically spent on their care due to systemic inequities.
So past injustice was baked into the algorithm's logic.
Exactly. Consequently, these systems gave higher priority to white patients for conditions like diabetes and kidney disease, even when black patients had objectively higher severity indexes. Historical injustice amplified. The COVID-19 pandemic tragically highlighted many of these issues. Biased AI systems exacerbated existing inequalities, placing vulnerable populations at higher risk, for instance, in allocating scarce resources where risk scores might have been biased. Rapid deployment meant thorough testing often didn't happen.
It's astonishing, these seemingly neutral tools automating and scaling up societal inequalities. What about gender bias beyond the LSE study? We hear about issues in cardiology, for example.
Yes, beyond race, gender bias significantly persists. In cardiology, heart attacks are frequently misdiagnosed in women, a well-documented clinical challenge, partly because women often present with atypical symptoms: fatigue, indigestion, not the classic chest pain more common in men.
Right.
This challenge is now compounded by AI prediction models for cardiovascular disease. Models trained predominantly on male datasets perpetuate this historical imbalance. Given that cardiovascular disease can present differently, an algorithm trained largely on male data may simply not be as accurate for women, leading to delayed diagnoses, poorer outcomes.
And this extends to drug development, too.
It does. Historically, clinical trials were male-dominated. That only began to shift relatively recently, following guidelines pushing for inclusion. Even preclinical animal studies were often male-biased. These historical biases directly transfer into datasets training AI for precision medicine or drug response prediction. This can lead to AI systems that don't accurately model how women react to new drugs, affecting dosage, side effect profiles, embedding bias into the AI's understanding of efficacy and safety.
It seems pervasive. Race, gender, what else?
Age bias is also prevalent. Automated sleep scoring algorithms, for instance. They perform well in research on young, healthy volunteers.
But not necessarily in the real world with older patients.
Precisely. They often fail miserably in clinical routines for older patients because they're trained primarily on data from the young and healthy. Sleep architecture changes significantly with age and comorbidities. The algorithms aren't fit for purpose for a large patient group. And finally, we must acknowledge human bias. AI is designed by humans. It reflects our unconscious judgments, our societal prejudices, a lack of diversity in the engineering, data science, biomedical teams creating these tools can lead to algorithms biased by design, unknowingly replicating prejudices.
So the team building the AI matters hugely.
Immensely. If a team lacks experience with diverse populations, they might create training data reinforcing diagnostic disparities. It's not just the data, it's the people, their perspective, their blind spots. Addressing this needs a multi-pronged approach, technical and human.
That's incredibly sobering. So what does this all mean for us, for medical professionals navigating this landscape, and for our patients? It means if we're not meticulously careful, if we don't apply an exacting standard of scrutiny, these tools designed to help could actually deepen existing inequities. Automating injustice. How can a busy clinician even begin to detect or challenge this?
That's a crucial question. And it speaks to the systemic challenge. Clinicians are often presented with these tools without full transparency on development or validation. But vigilance is key. Be acutely aware these biases exist. If something feels off, doesn't align with your clinical judgment for a patient, especially from an underrepresented group, question the AI's output.
Trust clinical judgment over the algorithm if there's a discrepancy.
Absolutely. If an AI risk score for a Black patient seems low, despite clinical indicators suggesting high risk, trigger a deeper human-led investigation. Advocate for transparency from vendors on training data and validation, especially on diverse populations. Ultimately, re-emphasize AI as a tool to assist, not replace, clinical expertise and ethical judgment.
Beyond the algorithms themselves, which are clearly a monumental concern, we need to talk about access and exclusion in digital healthcare. Ensuring this digital transformation serves everyone, not just the digitally proficient. Even with perfect algorithms, isn't there a fundamental hurdle of simply accessing and understanding these tools?
Absolutely. You hit on a critical distinction. Even with perfectly unbiased AI, the digital divide itself would still exacerbate health inequalities. This brings us to digital health inequalities, a topic well covered in the Access Denied white paper, crucial reading for healthcare strategy folks. It highlights a paradox. Digital channels offer immense benefits: convenience, reach, efficiency, booking appointments, accessing records, virtual consults.
Things we now take almost for granted.
Exactly. But there's a strong, concerning correlation between digital exclusion and social disadvantage. Individuals with protected characteristics under the Equality Act, older adults, those with disabilities, lower socioeconomic backgrounds, are often least likely to have reliable internet access and the necessary digital skills.
So it's the cost, the skills gap.
Yes, prohibitive costs of reliable internet, suitable devices, data plans. It makes digital health a privilege, not a right, effectively creating barriers if digital becomes the default gateway.
So it's not just availability, but usability and affordability. What does Access Denied recommend?
It puts forth clear, actionable recommendations for designers, developers, and NHS organizations implementing these tools. Blueprints for equitable design, really. Firstly, prioritize the highest standards for accessibility and usability. Foundational. Intuitive interfaces, compatibility with assistive tech like screen readers, simple language.
For clinicians, that means choosing systems committed to this.
Yes, Advocating for and selecting systems demonstrating this commitment, not just glossy interfaces. Secondly, thorough testing with a truly diverse cross-section of patients, providers, commissioners, not just the tech-savvy. Involve older adults, non-English speakers, those with disabilities, different socioeconomic backgrounds. Their feedback is invaluable. Thirdly, use data to optimize delivery and minimize exclusion over time. Continuously learn. Collect granular data on who is using services, who isn't, and why. Use that to drive improvements.
So constantly monitoring for disparities.
Constantly. Fourthly, understand different people need different channels. Digital first cannot mean digital only. Maintain phone lines, offer paper info, provide in-person support for online portals, which leads to the fifth point. Capture data to measure and compare outcomes and experience by channel. If a digital pathway leads to poor outcomes for a specific group, that's a red flag. Reevaluate.
Don't just assume digital is always better.
Precisely. Sixth, don't plan care pathways solely for the majority. Design proactively for minority and underserved backgrounds too, not as afterthoughts needing workarounds. Seventh, actively consider the support needed to transition people to digital pathways. Don't assume they can adapt. Offer training, free Wi-Fi, and clinics, loan devices. And eighth, equality impact assessments for transforming care pathways must explicitly address digital exclusion as a risk. Integrate a digital equity check into every new service. Ask, who might be left behind? The paper also calls for frameworks like those for information governance or clinical safety, guiding the mitigation of health inequalities by design, embedding equity from the start. And crucially, re-emphasizing ethical considerations must be built into the clinical safety case of any digital tool. Examining training data for bias isn't optional. It's integral to safety and quality.
That brings up an important point. We hear equality and equity used almost interchangeably, but you're arguing for a deeper principle justice. Can you elaborate on that distinction? Why is it vital here?
It's a crucial distinction, drawing from philosophy, but with profoundly practical implications. Let's break it down. Equality means giving everyone the same resources. In digital health, like giving every patient the same smartphone and portal access, regardless of circumstance.
Sounds fair on the surface.
But it often fails. It overlooks pre-existing barriers. Giving the same tablet to a visually impaired patient and one with perfect vision, or the same complex portal to someone digitally skilled and someone unfamiliar, it doesn't lead to fair outcomes. It ignores different starting points.
So equality can actually reinforce disadvantage.
Exactly. Equity goes a step further. It means taking individual circumstances into account to ensure fair outcomes, adapting resources and support. So large screen devices for the visually impaired, in-person guidance for those unfamiliar with tech, leveling the playing field by providing what each individual needs, moving beyond one size fits all.
Okay, so equity is about fair outcomes through tailored support. What about justice?
Justice transcends even equity. It demands we address the root causes of disparity. It's about systemic reform, not just temporary fixes or individual adaptations. Justice asks why these disparities exist and seeks to dismantle the structural barriers. John Rawls' difference principle is relevant. Inequalities are acceptable only if they benefit the least advantaged. In digital health, this means looking beyond adjusting individual access, address systemic issues. Why are there digital deserts? Why is digital literacy low in certain groups? Why does algorithmic bias persist?
So justice means tackling the societal structures, not just the symptoms.
Precisely. This is where digital determinants of health, DDH, become paramount. Like social determinants, income, education, DDH highlights factors like reliable infrastructure access, broadband, digital literacy, cultural inclusion, language, sensitivity, and algorithmic fairness itself. These interact profoundly with traditional social determinants, exacerbating or ameliorating inequalities. A patient in a rural digital desert is doubly disadvantaged if their GP goes digital first.
So how do we operationalize justice?
Through a structural approach. Advocating for policies addressing digital deserts, tackling algorithmic bias with rigorous testing and ethics, rebuilding trust with marginalized communities, implementing supportive infrastructures like digital facilitators, professionals, or trained community members assisting users with digital services, like a digital concierge in healthcare, and crucially, co-creation, designing digital tools and policies with direct input from underserved populations, ensuring solutions are responsive to their lived realities, not imposed top-down.
And a huge part of this puzzle, as you touched on, is digital health literacy. It's clearly more than knowing how to click a button, isn't it?
Precisely. It's far more nuanced. It encompasses the understanding, the trust, and the confidence individuals need to effectively engage with digital health interactions. It includes seeking, finding, comprehending and critically assessing health information online, distinguishing reliable advice from misinformation, and applying that knowledge. It reminds me of, well, anyone trying to navigate a complex new system. What seems intuitive to some is a labyrinth to others. And when it's your health, that frustration has real consequences.
And this literacy isn't evenly distributed.
No, far from it. Significant disparities exist, particularly among older adults. In the EU, only about 28.5% of 65-74-year-olds have basic or higher digital skills, dropping dramatically with age. Persons with disabilities, those with limited socioeconomic resources, also face significant barriers. Often the very groups who could benefit most from digital care but lack the literacy. It widens the divide.
So what are the solutions? How do we bridge that literacy gap?
They must be multifaceted, integrated into clinical workflows, targeted education for users and healthcare professionals. Providers need to be adept at integrating tools ethically, understanding patient challenges. Genuine co-designing of policies and tools with vulnerable groups is essential. The Pro-Patient Decalogue in Catalonia is a prime example, collaboration with patient associations outlining principles for patient-centered digital health, ensuring solutions reflect lived realities, building trust.
Are international bodies focused on this?
Increasingly, the WHO's Digital Health Action Plan for 2023-2030 explicitly prioritizes capacity building and literacy enhancement, foundational goals. But improving literacy can't be viewed in isolation. It must be part of a larger structural effort. Robust ethical governance, interoperability mandates, addressing intersectional inequalities. Only then can digital health's promise extend to all.
All of this brings us to the critical question. So how do we actually do this? How do we build systems that bridge these divides and ensure fairness in practice, moving beyond identifying problems to implementing tangible solutions in our healthcare settings?
This is indeed the crucial next step for professionals and leaders. We can learn a great deal by examining the equitable implementation of telehealth, especially given its rapid scaling during COVID-19. That period, while showing incredible agility, also highlighted profound unintended consequences. Without proactive planning for equity, telehealth often reinforced disparities.
It solved one problem but created others.
In some ways, yes. To guide a more equitable approach, we could use integrated frameworks blending implementation science with an equity lens. One effective combination is the EPI's framework exploration, preparation, implementation, and sustainment with the Digital Health Equity Framework, or DHEF.
Okay, EPS and DHEF, can you break those down slightly?
Sure. EPS provides a structured four-phase approach: exploring the problem, preparing for an intervention like telehealth, implementing it effectively, and sustaining it long-term. DHES adds the vital equity lens. It pushes us to consider how internal factors in the organization, leadership, staff capacity, resources, culture, and external factors, policies, reimbursement, community digital infrastructure impact equity. Crucially, DHEF views the health system itself as a social determinant of health. Organizations must look beyond patient-level factors to lead with equity and address systemic bias.
Can you walk us through a concrete example, perhaps that shift to web-based physical therapy during the pandemic? That seems very relevant.
An excellent example: pre-pandemic, web-based physio adoption was slow. Barriers like reimbursement, lack of infrastructure, insufficient provider training. When the pandemic hit, necessity drove an almost overnight shift from nearly 100% in-person to nearly 100% outpatient physio, a monumental logistical feat.
But with equity consequences.
Significant ones. The patient demographics reached by web-based services shifted dramatically. They were overwhelmingly younger than 65, non-Hispanic white, English-speaking, commercially insured, few comorbidities. A stark contrast to the more diverse in-person base pre-pandemic: older, Asian, non-English-speaking, non-commercially insured, often with comorbidities.
So it immediately highlighted unequal access for those already struggling.
Yes, leading to delayed or foregone care for vulnerable populations. A geriatric patient with complex mobility issues, lacking tech or literacy, simply couldn't access crucial rehab, potentially worse functional outcomes.
That scenario truly highlights the practical implications at the patient level. It really underscores the need for bridging solutions, ways to connect our internal health systems with the external realities of diverse patients, making sure no one falls through the cracks.
That's it, exactly. These bridging solutions are critical, actionable strategies. We can identify three key areas for equitable telehealth implementation, generalizable beyond physio. First, community partnerships. Truly the backbone of successful implementation, aiming for equity. They enable crucial bidirectional information flow, aligning telehealth goals across systems, patients, policies.
How would that have helped in the physio scenario?
Robust partnerships, right from the exploration preparation phases of EPI, would have been necessary to identify who was receiving care, who wasn't, and why. This means intentionally involving impacted community members, older adults, non-English speakers, rural residents, those with disabilities in the design, testing, evaluation.
Co-designing with the end users.
Essential. It helps adapt services to sociocultural contexts, addresses barriers, increases relevance and effectiveness for marginalized groups, builds trust, co-designing patient materials, piloting in community centers, for example. Second, fostering shared mental models, nurturing shared beliefs, understandings, expectations about how care works across everyone involved: patients, providers, administrators, policymakers,
Shared understanding of what telehealth is and can do.
and what its limitations are and for whom. For physio, adjusting perceptions of web-based care post-pandemic. Discordant mental models unintentionally hinder access. For instance, requiring an initial web-based visit blocks those without internet or privacy. Or patients uncomfortable discussing sensitive topics online. That's a conflict hindering access.
How do you build shared models?
Convene diverse groups. Ask open questions. What's a successful telehealth episode for all patients? What criteria suggest other modalities are needed? Map clinic workflows, patient journeys to find where people fall through the cracks. Practice facilitation is valuable here. Train facilitators working with clinicians to help them internalize equitable approaches, using tech empathetically. And third, robust digital infrastructure, bridging human and technical resources for effective, equitable telehealth.
More than just devices.
Much more. Broader advocacy for reimbursement, sustained public-private investment in digital infrastructure everywhere. For physio and all specialties, systematically measure individual factors: tech skills, equipment access, preferences, and community metrics, Wi-Fi availability, transportation options if digital isn't suitable.
Using data to drive policy and oversight.
Exactly. Highlighting digital deserts, low literacy communities. This infrastructure must be co-designed with community input, responsive to real needs, not just technical specs. Transparency in data sharing, stringent privacy security management, the ethical bedrock, building trust. These three bridging solutions, implemented intentionally, move us towards a just digital health landscape.
That's a truly comprehensive framework. It's clear this isn't just about pandemic recovery, it's about building a fairer future system. What are the immediate priorities as telehealth persists and expands?
Exactly. Continuous evaluation and adaptation are key. Recommend evaluating hybrid care models, blending digital and in-person based on need, preference, clinical appropriateness, moving beyond a binary choice. Systematically identify multi-level barriers and facilitators to adapting tech resources for diverse populations. Look at individual, provider, organizational, policy levels.
And digging into the complexity of disadvantage.
Critically, explore the intersectionality of telehealth access. How do age, race, ethnicity, sexual orientation, disability, socioeconomic status, social determinants, digital literacy, rural-urban residents interact? An elderly, low-income, rural patient with a visual impairment faces multiple compounding barriers, requiring a multifaceted, individualized approach. This intersectional analysis reveals the complex layers. Reasserting it's through intentional application of bridging solutions, community partnerships, shared mental models, digital infrastructure that we genuinely alleviate these issues and move towards truly equitable digital health.
Now, Professor, let's zoom out to the global picture. How are countries embedding these principles of fairness and inclusion into their broader national digital health strategies? Are we seeing these vital considerations translate into policy at scale? Are they learning from these insights?
That's an excellent question. A recent comprehensive WHO University of Warwick review provides some illumination. They examined 20 national digital health strategies from various countries, different income levels. It maps where strategies align and where significant gaps remain. On the positive side, several good practices emerged, areas where countries are largely getting it right. Firstly, privacy, data security, and confidentiality are widely recognized. Foundational pillars. Most strategies acknowledge these. 11 of 20 explicitly reference privacy data protection as core principles. Others indirectly reference data security governance. Countries like Indonesia, South Africa, Brazil, Sri Lanka are strengthening regulatory frameworks, incorporating privacy and security by design.
Meaning building it in from the start, not as an afterthought.
It's exactly crucial for patient trust. Secondly, many strategies commendably build upon existing local regulatory frameworks, addressing existing ICT regulations, AI policy, broadband access, health legislation. Some, like the Kyrgyz Republic and South Africa, propose new legislation defining health rights, showing a proactive approach. Estonia plans a dedicated ethics legal group to continuously review legislation. Thirdly, a strong trend towards clear implementation plans, accountability, transparency. Impressive 80%, 16 of 20, include detailed plans, indicators, timelines, budgets, assigned tasks.
So, proper project management.
Yes. Brazil uses graphics showing stakeholder cooperation. Ghana has tables outlining objectives, agencies, timelines. Laos uses do now, do soon, do later. Jamaica, Sierra Leone have detailed budgets, monitoring frameworks, crucial for translating intentions into outcomes.
So foundational elements seem okay in many places, secure, well-managed digital health. But I suspect gaps remain, especially on equity and inclusion.
Your suspicion is absolutely correct. Despite commendable practices, the review found significant gaps directly relating to the ethical and justice issues we've explored. Most strikingly, a widespread lack of holistic gender consideration. Truly alarming. None of the 20 strategies holistically address gender inequalities, essentially gender blind.
None at all.
Mentions of gender or women were extremely rare. Sierra Leone noted need for a gender-sensitive workforce, but no specific actions for the population. This gender blindness undermines equity and justice principles. It means countries are building digital futures that implicitly ignore half their population's unique needs and barriers, compounding the kind of AI biases we discussed, but on a national scale.
Leading to female conditions overlooked, resources not reaching women.
Widening gender health disparities. Furthermore, a limited rights and equity lens. Few explicitly integrated human rights principles into their core vision. Exceptions like Sri Lanka, right to health, Kyrgyz Republic, constitutional rights existed, but none explicitly mentioned non-discrimination, freedom of expression, autonomy, privacy, sexual reproductive health rights.
Just generic calls for equitable access.
Common, yes, but lacking specifics on how for diverse populations, leaving it open to interpretation, potentially unaddressed. Absence of an explicit rights-based approach leaves vulnerable groups without clear safeguards, a particularly significant concern. Lack of inclusion for diverse populations. Only 2 of 22 genuinely targeted approaches. China was notable. Detailed consideration for persons with disabilities, proposing a database, ethnic minorities, language needs in tech, older people with concrete interventions. Laos considered rural remote populations, outlining actions like telemedicine with local language support. South Africa mentioned facilitating digital health for people with HIV. UK highlighted improving data for social care, child safety.
But many others were just generic.
Many offered only generic references to hard-to-reach or rural groups without concrete plans or disaggregated data. Virtually no interventions for highly vulnerable groups like migrants, refugees, or those seeking sexual reproductive health care. Digital health transformation may inadvertently bypass those most in need. We also saw pervasive missed opportunities for collaboration. Limited engagement with local authorities. Only Brazil, South Africa recognized local health councils' importance, vital for ground-level impact. Significant lack of cross-ministerial collaboration. Ministries of women, youth, human rights institutions rarely consulted. Siloed policies.
And consultation with the public, with communities.
Strikingly limited. Only 5 of 20 explicitly mentioned such engagement. Ghana, a rare exception listing a youth representative. Lack of public feedback mechanisms means strategies may not reflect lived realities or needs, leading to low uptake or failure. Finally, emerging issues were often underexplored. Focus on current tech, often missing challenges from advanced AI, neurotechnology, unregulated private health fitness apps.
So not looking ahead sufficiently.
Often not. Little attention to governance of sensitive data held by private apps or social media's impact on health info, misinformation, and mental health. South Africa, Indonesia were among the few considering advanced AI or mobile app repositories. Similarly, widespread digital health literacy gaps for the public. Most strategies focus training on the healthcare workforce, 15-20, significantly less on the general public. Where public training was mentioned, it often focused narrowly on basic digital skills, not crucial gender, ethics, human rights considerations. Lebanon was rare, proposing coordination between ministries for a public digital learning platform. Lack of public literacy support makes even excellent tools inaccessible or mistrusted.
These global findings underscore a critical truth, don't they? While digital health offers immense promise, fulfilling it, particularly for the most vulnerable, requires intentional, integrated, ethically guided strategic planning and action at every single level. It's not enough to simply adopt technology. We must consciously design for inclusion, constantly scrutinize the ethics.
Absolutely. Without that intentionality, the tools designed to bridge gaps could inadvertently widen them.
This deep dive has truly shown us that the digital transformation of healthcare, while inevitable and full of potential, is not inherently fair or universally accessible. It demands our active, informed participation, our critical thinking, to ensure it genuinely serves all patients equitably, rather than inadvertently automating and scaling existing inequalities. We've explored the pervasive issue of bias in AI and digital health, highlighted the crucial distinction between equality, equity, and the systemic demands of justice. We've delved into bridging solutions like community partnerships and robust digital infrastructure, and seen the vital need for national strategies that genuinely consider gender, rights, and diverse populations.
Indeed, knowledge is most valuable when understood and applied with critical insight. The discussions today highlight that critical thinking, constantly questioning assumptions, are essential as we integrate these powerful technologies into clinical practice. The ethical considerations must always remain front and center, guiding our decisions in development, implementation, and ongoing oversight.
Thank you for joining us on this deep dive. If you found this discussion valuable, please take a moment to rate and share our deep dive with a colleague who might also benefit from these crucial insights. As we stand on the precipice of a fully digitized healthcare future, consider this. Are we building systems that truly empower every individual to thrive, or are we simply automating existing inequalities, making them harder than ever to see and harder than ever to fix? This has been The Deep Dive.